Welcome to the MRCPology channel for a quick review, understanding, and revision of the topic. Imagine an older patient who is becoming progressively unsteady. The family says the feet seem stuck to the floor, thinking has become slower, and urinary urgency has progressed to incontinence. The immediate temptation may be to diagnose Parkinsonism, vascular dementia, or simply age-related decline. However, this combination should make you consider normal pressure hydrocephalus, because it is one of the potentially treatable causes of cognitive and functional deterioration in older adults. Normal pressure hydrocephalus is a communicating hydrocephalus caused by impaired cerebrospinal fluid resorption. Cerebrospinal fluid gradually accumulates within the ventricles, producing ventriculomegaly and dysfunction of the surrounding periventricular pathways. The term normal pressure can be misleading. It does not mean that cerebrospinal fluid pressure is always normal. Pressure may rise intermittently, but a lumbar puncture performed between these pressure elevations may show a relatively normal opening pressure. To understand the disorder properly, first follow the normal circulation of cerebrospinal fluid. Cerebrospinal fluid is produced mainly by the choroid plexus within the ventricles. It flows from the lateral ventricles through the foramina of Monro into the third ventricle. From there, it passes through the cerebral aqueduct into the fourth ventricle. It then exits through the foramen of Magendie and the foramina of Luschka, enters the subarachnoid space, and circulates around the brain and spinal cord. Finally, it is absorbed through the arachnoid villi and arachnoid granulations into the dural venous sinuses, particularly the superior sagittal sinus. In normal pressure hydrocephalus, these ventricular pathways remain open. This is why it is described as communicating hydrocephalus. The problem lies at the level of cerebrospinal fluid absorption, usually at the arachnoid granulations. Impaired absorption leads to gradual accumulation of cerebrospinal fluid within the ventricles. The ventricles enlarge, and this enlargement stretches and compresses the surrounding periventricular white matter tracts. The clinical features can then be understood according to which pathways are affected. The frontal gait circuits and corticospinal pathways run close to the lateral ventricles. When these pathways are stretched, the patient develops a characteristic gait disorder. Frontal subcortical circuits are also affected, producing executive dysfunction, slowed thinking, poor attention, and apathy. Periventricular fibers involved in the control of micturition become disrupted, causing loss of frontal inhibition of the bladder reflex and resulting in detrusor overactivity. So the mechanism can be remembered as a simple spoken flow. Impaired cerebrospinal fluid absorption leads to ventricular enlargement. Ventricular enlargement stretches periventricular pathways. Damage to frontal gait circuits causes gait apraxia. Damage to frontal subcortical circuits causes cognitive slowing. Damage to descending bladder control fibers causes urinary urgency and incontinence. Normal pressure hydrocephalus may be idiopathic, particularly in older adults. It may also occur secondary to conditions that interfere with cerebrospinal fluid absorption, including subarachnoid hemorrhage, meningitis, head trauma, and previous neurosurgery. Now consider the clinical presentation. The classic triad is often remembered as wet, wobbly, and wacky, referring to urinary incontinence, gait disturbance, and cognitive impairment. However, the sequence is important. The gait disturbance is usually the earliest and most prominent feature. The gait is often described as magnetic. The feet appear to stick to the floor. The patient takes short, hesitant steps, often with a broad base, and may have particular difficulty initiating walking or turning. The upper body may move forwards while the feet remain planted. Despite this, power in the legs may be relatively preserved. This is not weakness in the usual sense. The patient has difficulty activating and coordinating the learned motor program required for walking. This is why the gait disturbance is sometimes called gait apraxia. The key clue is that gait initiation is disproportionately impaired. Patients may struggle to walk, but can sometimes perform stepping movements more effectively while sitting or lying down. The problem is therefore not simply muscle weakness, sensory loss, or cerebellar incoordination. Do not confuse this with Parkinson's disease. Both conditions can cause short steps and difficulty initiating movement. However, normal pressure hydrocephalus usually produces a broader-based, magnetic gait with prominent postural instability and relatively less upper limb involvement. Parkinson's disease is more likely to produce a narrow-based shuffling gait, reduced arm swing, rigidity, bradykinesia, and sometimes a resting tremor. The cognitive impairment in normal pressure hydrocephalus has a frontal subcortical pattern. Patients develop psychomotor slowing, reduced attention, impaired planning, poor concentration, and apathy. They may appear withdrawn or slow to respond. This differs from the early cortical pattern seen in Alzheimer's disease, where episodic memory impairment is often more prominent. Aphasia, apraxia, and agnosia are not usually the dominant early features of normal pressure hydrocephalus. The urinary disturbance usually begins with urgency and frequency. It may then progress to urge incontinence. The mechanism is loss of frontal inhibition of the bladder reflex, leading to involuntary detrusor contractions. In advanced disease, the patient may become incontinent partly because of the combination of bladder dysfunction, cognitive impairment, and reduced mobility. MRCP trap, the complete triad, does not need to be present. An older patient with a characteristic magnetic gait and ventriculomegaly may still have normal pressure hydrocephalus even before significant cognitive impairment or incontinence develops. Investigation begins with brain imaging. Computed tomography or magnetic resonance imaging shows ventriculomegaly. The important point is that the ventricular enlargement is disproportionate to the degree of cortical atrophy. Enlarged ventricles alone are not enough because ventricles also enlarge when brain tissue is lost, a process known as hydrocephalus ex vacuo. In normal pressure hydrocephalus, look for enlargement of the lateral and third ventricles, tight sulci over the high cerebral convexities, and enlarged sylvian fissures. Periventricular signal change may also be present, reflecting transependymal movement of cerebrospinal fluid into the surrounding white matter. The imaging pattern of tight, high-convexity sulci with enlarged sylvian fissures supports the diagnosis and helps distinguish normal pressure hydrocephalus from generalized cerebral atrophy. In cerebral atrophy, both the ventricles and the cortical sulci are enlarged because brain volume has been lost. In normal pressure hydrocephalus, ventricular enlargement is out of proportion to the cortical sulcal enlargement, and the high-convexity sulci may actually appear compressed. A lumbar puncture often shows a normal or only mildly elevated opening pressure. A normal opening pressure does not exclude the diagnosis. The most useful predictive bedside investigation is a large volume lumbar tap test. A substantial volume of cerebrospinal fluid is removed, and the patient's gait is assessed objectively before and after the procedure. Assessment may include walking speed, step length, turning, or a timed walking test. Improvement after cerebrospinal fluid removal supports the diagnosis and suggests that the patient may respond to shunt surgery. Gait improvement is generally easier to demonstrate than cognitive improvement because gait can be measured immediately and objectively. A negative tap test does not absolutely exclude shunt responsiveness, particularly when the clinical and imaging features are strongly suggestive. In specialist practice, prolonged lumbar drainage or more detailed cerebrospinal fluid dynamic testing may be considered in selected patients. The main differentials are Alzheimer's disease, vascular cognitive impairment, Parkinsonism, and age-related cerebral atrophy. The clinician should ask which feature came first, what the gait actually looks like, whether there are focal neurological signs, and whether the imaging shows true hydrocephalus or simply ventricular enlargement due to loss of brain tissue. Vascular disease may produce gait impairment, cognitive slowing, and urinary symptoms, making it a particularly important mimic. Look for a stepwise history, focal deficits, extensive vascular lesions on imaging, and other evidence of cerebrovascular disease. However, vascular pathology and normal pressure hydrocephalus may coexist. The definitive treatment is cerebrospinal fluid diversion, most commonly with a ventriculoperitoneal shunt. The shunt drains cerebrospinal fluid from the ventricles into the peritoneal cavity. This reduces ventricular distension, decreases stretching of the periventricular pathways, and may improve neurological function. Gait is usually the symptom most likely to improve. Urinary symptoms may also improve, although the response is more variable. Cognitive impairment is the least predictable feature, particularly when it is advanced or when there is coexisting Alzheimer's disease or vascular pathology. If you remember one thing, remember this. An older patient with a magnetic gait, frontal cognitive slowing, urinary urgency, and ventriculomegaly, disproportionate to cortical atrophy, may have a surgically treatable condition. Shunt surgery is not without risk. Overdrainage can cause the brain to pull away from the dura, stretching and tearing bridging veins and producing a subdural hematoma. Other complications include shunt infection, obstruction, malfunction, and intracranial hypotension. The decision to proceed to shunting therefore depends on the strength of the clinical diagnosis, the imaging findings, the response to cerebrospinal fluid drainage, the patient's overall health, and the likelihood that the symptoms are genuinely attributable to normal pressure hydrocephalus. MRCP trap. Ventriculomegaly plus dementia does not automatically mean normal pressure hydrocephalus. The clinical gait pattern, the disproportion between ventricular size and cortical atrophy, and the response to cerebrospinal fluid removal are essential parts of the assessment. Quick recall: an older patient has short steps, difficulty initiating gait, urinary urgency, and slowed executive function. Imaging shows enlarged ventricles with tight high-convexity sulci and enlarged sylvian fissures. What is the most useful test for predicting benefit from treatment? The answer is a large-volume lumbar tap test with objective gait assessment before and after cerebrospinal fluid removal. Improvement supports likely responsiveness to shunt surgery. A patient with suspected normal pressure hydrocephalus undergoes ventriculoperitoneal shunting and later develops headache, confusion, and a reduced level of consciousness. Imaging shows a crescent-shaped extraaxial collection. What is the likely complication and what is the mechanism? The answer is a subdural hematoma caused by cerebrospinal fluid overdrainage, which reduces intracranial support and stretches the bridging veins until they tear. Do subscribe to the channel for further videos.